Hey, welcome back to Not So Complicated, and it's day 11, clinical case discussion 11, and like always, my friend, let's go tap into this clinical case. And today we have a 55-year-old male presents to the emergency department with a 2-day history of severe left foot pain, swelling, and fever. He reports a 1-month history of a non-healing ulcer on his left heel after a minor abrasion. Medical history includes type 2 diabetes mellitus. So it may be a case of diabetic foot ulcer, but not only in the cases of diabetes, the ulcers occur. There can be peripheral artery disease, sarcoid neuroarthropathy, or necrotizing fasciitis. Anything can be there. So also peripheral neuropathy and smoking 20 pack years. Vitals include temperature 38.8 degrees Celsius, BP 150 by 90 mmHg, pulse 110 per minute, and then respiratory rate 20 per minute. An examination, there is a 3 centimeter deep ulcer in left foot, foul smelling discharge, erythema, and bony tenderness. Now we have some more information in here. And the lab showed that WBC is 19,000 per microliter, 82% are neutrophils, so there is an underlying infection. And also glucose is 350 mg per deciliter, which is very uncontrolled in the patient is in glycemic stage. And ESR is 70 mm per hour. X-ray shows cortical erosion of calcinus, and MRI shows bone marrow edema, soft tissue abscess. So which of the following is the most likely diagnosis? Cellulitis, diabetic foot ulcer with osteomyelitis, necrotizing fasciitis, peripheral artery disease with gangrene, and sarcoid neuroarthropathy. So even if we can diagnose until now, we will debunk each of these options first, so that in details, so that we know the information in each of these options too. So basically the first option we have is cellulitis, and cellulitis is actually a superficial bacterial skin infection, often due to streptococcus or staphylococcus aureus, and it presents with erythema, warmth, and swelling as seen in here. However, this patient's deep ulcer, foul smelling discharge, bony tenderness, and imaging where it shows cortical erosion and bone marrow edema indicates bone involvement, ruling out superficial cellulitis, right? So the systemic signs and chronicity suggest a deeper infection like osteomyelitis, and cellulitis lacks bony changes on X-ray and typically responds to antibiotics without surgical debridement. So basically it is very highly unlikely in this case. Even if it is unlikely, let's tap into the pathogenesis or the treatment of this cellulitis. So if a patient is presented with cellulitis, this can be outpatient non-purulent cellulitis or outpatient purulent cellulitis and hospitalized patient with cellulitis. So in outpatient non-purulent cellulitis, there should be treatment for streptococci and MRSA, which is methicillin resistant staphylococcus aureus, given by cefalexin, dicloxacillin, and clindamycin, and empiric coverage for a community-acquired MRSA if no response or systemic toxicity is there. And in outpatient purulent cellulitis, we give treatment for CA-MRSA, that is clindamycin, TMP, SMZ, doxycycline, and linezolide. And then in the hospitalized patient with cellulitis, we give treatment for MRSA like vancomycin, linezolide, and daptomycin, telebenzin, and clindamycin. If non-purulent cellulitis, then we have to consider treatment for streptococci and MSSA or MRSA with modification to MRSA active therapy if there is no response. So that is all about cellulitis I have to read now. And then the next option we have is diabetic foot ulcer with osteomyelitis. So let's debunk it. It is usually poorly controlled. It usually occurs due to poorly controlled type 2 diabetes mellitus is in this case, where SbA1c level is 8.9% with a chronic non-healing left heel ulcer, severe pain, swelling, fever, foul smelling discharge, and indicating infection. And there is also bony tenderness, leukocytosis, elevated ESR, and also cortical erosion, bone marrow edema, soft tissue abscess, which indicates that there is osteomyelitis and also a diabetic foot ulcer. And peripheral neuropathy, a history of peripheral neuropathy in this case has must be an unnoticed trauma leading to ulceration, while hyperglycemia impairs immune response, causing deep infection. So even there is superficial infection, it can lead to the deep ulceration due to delayed wound healing in the case of diabetes mellitus. And MRI's bone marrow edema, and then X-rays cortical erosion are specific for osteomyelitis. So it is highly likely that this is a case of diabetic foot ulcer with osteomyelitis, but still we will tap into other options, right? So the foot ulcer is usually graded in six if started from 1, and 5 grades if started from 0. So grade 0 is there is no open lesion, and grade 1 is superficial ulcer, then grade 2 is deep ulcer, then grade 3 is abscess osteitis, grade 4 is gangrene forefoot, and then grade 5 is gangrene entire foot. That is what it happens. And also in the third option we have is necrotizing fasciitis. Necrotizing fasciitis is actually a rapidly progressive soft tissue infection, often polymicrobial or group A streptococcus, which causes severe pain, erythema, crepitus, and systemic toxicity. While this patient has fever, erythema, and leukocytosis, chronic 1-month ulcer, bony tenderness, and cortical erosion, and also bone marrow edema leads to osteomyelitis, not fascial necrosis. So necrotizing fasciitis typically shows gas in soft tissues on X-ray or CT, not bone destruction, and also progresses within hours, not weeks, because this case there is a history of 1 month non-healing heel ulcer, right? And also the foul smelling discharge and abscess suggests deep infection. So this is very highly unlikely. But necrotizing fasciitis can be graded in 3 stages. Then in early stage there is tenderness to palpation, extending beyond the apparent area of skin involvement, erythema, swelling, calor, which is warm skin, and stage 2 is intermediate, where it occurs to have blister or bulle formation with serous fluid and skin fluctuations. And the grade 3 or stage 3 is late case, and it has clinical features like crepitus, skin anesthesia, crepitation, and skin necrosis with dusky discoloration, tissue necrosis progressing to gangrene. That is all about necrotizing fasciitis. And the fourth option we have here is peripheral artery disease with gangrene. So peripheral artery disease with gangrene is common in diabetics and smokers, since there is 20 years of history of smoking in here. And it also causes ischemic ulcers, cool extremities, and dry black tissue. Patient's fever, leukocytosis, foul-smelling discharge imaging indicate active infection, osteomyelitis, not ischemic gangrene. So this is the point that distinguishes diabetic foot ulcer with peripheral artery disease with gangrene, that it has an active infection, not ischemic gangrene. But there is an overlap of symptoms where there are overlap of risk factors like diabetes and smokers, and also symptoms like fever, leukocytosis, and also dry black tissue, ulcers. That is what we have to distinguish first. And then in peripheral artery disease, ulcers are typically painless due to neuropathy, unlike the severe pain in here, and lack systemic signs unless secondarily infected. The MRI abscess and bone changes confirm osteomyelitis over vascular insufficiency, though peripheral artery disease may coexist, which is not addressed by pulses and vignette. So peripheral artery disease is most often caused by atherosclerosis, plaque formation in arteries that supply blood to the extremities, such as legs and arms, right? When these fatty deposits collect in arteries and harden, it narrows the opening and blocks effective blood flow. Since effective blood flow is blocked, there is the reduced flow of nutrition and oxygen, which causes ischemia, and that ischemia causes ischemic ulcer and also gangrene in long term. So last option we have is Charcot neuroarthropathy, a neuropathic joint destruction in diabetics. So it also occurs in diabetics, presents with painless swelling, but there should be pain and an ulcer in the case of diabetic foot, right? And the painless swelling, deformity, and warmth, often mimicking infection, since it has also fever, leukocytosis, foul-smelling discharge, bony tenderness, and imaging features indicate osteomyelitis, not Charcot. And also Charcot shows mid-foot collapse or joint subluxation on X-ray, as I have attached in the figure right here. So there is a subluxation of X-ray or mid-foot collapse, as you can see in the figure. And also It doesn't show any cortical erosion and lacks systemic infection signs. The 1 month ulcer and abscess suggests bacterial invasion, not neuropathic bone fragmentation. While neuropathy predisposes to both, the infectious profile rules out Charcot. So this is also unlikely. So we have to dive into our diagnosis, and the diagnosis is diabetic foot ulcer with osteomyelitis. The mechanism of diabetic foot ulcer with osteomyelitis is that in the cases of diabetes there are three major symptoms, that is neuropathy, vascular insufficiency, and secondary infection. These are the very much risk factors, right? And the neuropathy leads to the sensory loss, motor neuron dysfunction, and autonomic dysfunction. And then vascular insufficiency leads to ischemia, which leads to impaired wound healing and also decreased oxygen supply in the wound. And secondary inflammation, impaired wound healing, and reduced angiogenesis. These all factors combine to develop into a diabetic foot ulceration. Here is also the mechanism in figure, where there is hyperglycemic state and the patients prone to diabetes mellitus. They have nerve damage and also vasculopathy in the blood vessels due to the formation of plaques, which reduces blood flow, and blockage of blood flow and decreased blood flow and damaged nerves. They tend to form an ulcer, and the premature cell degradation occurs. Abnormal M1, MP, neuropathy disorders, active ECM, extracellular matrix growth factors, and stromal cells then lead to damaged ECM, growth factors, and stromal cells. That there is also reduced angiogenesis in there. These all factors contribute to the development of diabetic foot ulcer. And if the foot ulcer is deep enough, the infection might spread into the bone regions, which is causing osteomyelitis in right here. So the clinical features you can see in the figure, right? In the upper figure, there is the raw gross graw footages and also the corresponding X-ray footages, where there is the osteomyelitis in a diabetic foot. There is increased intensity of infection in the X-rays, as you can see. And the clinical features, there are stages. The first stage is that we feel tingling, burning, or pain in our feet, and then a change in the color and temperature of our feet. And also then there is dry, cracked skin on your feet, and then there is loss of feeling or ability to sense heat or cold, and then there is thick yellow toenails and loss of hair on your toes, feet, and lower legs, a fungus infection such as an athlete's foot between your toes, and also then an ingrown toenail or a sore such as a blister, ulcer, or infected corn. That is what happens, right? So we have to tap into the management of diabetic foot now. The management is often surgical debridement, urgent surgical debridement to remove necrotic tissue, drain the abscess, and excise infected bone, calcineal resection if limited, and also intraoperative bone cultures guide antibiotic therapy. So if the infection is extreme, then there is a risk of foot amputation, and the risk of foot amputation is 15 times higher in diabetics compared to non-diabetics. And we have to also administer antibiotics, empiric IV antibiotics, vancomycin 15 mg per kg Q12 hour, plus piperacillin tazobactam 4.5 gram Q8 hour to cover MRSA, methicillin resistant Staphylococcus aureus, gram negatives, and anaerobes, the adjusted per culture results. And the duration 4 to 6 weeks for osteomyelitis, IV for 2 to 4 weeks, then oral. We have to prevent the infection, right? So that the lesion does not increase the intensity. And we have to also control the glycemia by insulin therapy. Example, sliding scale, titrate to glucose less than 180 mg per deciliter to optimize wound healing and immune response. We have to monitor SbA1c in long term. SbA1c is actually glycated hemoglobin. We'll talk about it in our study with me series of first aid. So you can subscribe in there. And also there should be supportive care, right? There should be wound care, offloading with total contact cast, and or non-weight bearing crutches to reduce pressure on the heel. Daily dressings with antimicrobial agent silver sulfadiazine to prevent the infection. Obviously, we need to prevent the infection. And the pain management via IV morphine 2 to 5 mg/q per hour, or tramadol 50 mg/q 6 hour for severe pain titrated to response. And infection monitoring, recheck WBC, ESR, and CRP weekly. And also persistent elevation suggests treatment failure. We have to repeat MRI if there is no improvement after 2 weeks. And the ulcer grading occurs in 6 stages. I have already said about it, but you can also revise it in here. No ulcer but high risk foot, superficial ulcer, deep ulcer, no bone involvement or abscess, abscess with bone involvement is shown by X-ray, and localized gangrene, example toe, heel, then extensive gangrene involving the whole foot. That is our grading. Then grade 1 to 3 ulcers are termed non-gangrenous ulcers, and 4 and 5 are termed gangrenous ulcers. And there is the picture of surgical debridement as I have attached in there for osteomyelitis too. And in the long-term management, we have to do revascularization, assess peripheral pulses if absent in a smoking history, obviously, and we have to consider angiogram and angioplasty for ischemia. And rehabilitation, physical therapy post-steering to restore mobility, and if the patient leads to an amputation, then also we have to do the rehab. We have to custom orthotics to prevent recurrence. Risk factor modification, smoking cessation counseling because 20 pack years of history, nicotine patches 21 mg per day, and then optimize diabetes, target SBA1C less than 7% and hypertension. We have to give lisinopril 20 mg daily. Lisinopril is an ARB, angiotensin receptor blocker. And also follow up weekly wound clinic visits, 3-month MRI to confirm osteomyelitis resolution. Recurrence risk is 30 to 40% within 1 year. So that is how we wrap up our day 11 clinical case. Subscribe for the next cases. Thank you so much for staying with me, and also subscribe for the Study With Me series for USMLE First Aid Step 1. Thank you.